Good morning, everyone, and Sammy, thank you for those kind words. I just want to emphasize again that I will aim to answer as many questions as possible, and there will be plenty of time to answer the questions when I finish my presentation. So this is going to be a talk about Cushing's disease, as seen on the first slide here. And what I'm going to talk about is really, as Sammy has just said, I want to talk about what Cushing's disease is. I want to talk about what the clinical features are, and that will then lead me in to discuss what the various tests and scans are needed to make a proper diagnosis. And then following on from that, what are the treatment options? And importantly, a question which I think is very important and very important for the patient community is really how should patients expect to feel after they've had pituitary surgery, or indeed any other treatment for active Cushing's, but our focus this morning is on Cushing's disease from the pituitary. So what is Cushing's? Well, you'll notice there's a title change here, because when someone comes with the symptoms and signs of Cushing's, it's Cushing's syndrome that we consider. We don't know when we first see someone what the cause of their Cushing's is. And it's down to the biological effects of having too much of the hormone cortisol, which comes from the adrenal gland. They're two tiny glands which sit just on top of your kidneys. And of course, more commonly, far more commonly than having Cushing's coming from within your body, is if people are on steroid treatment. So if people are on steroids, either tablets or inhalers or topical preparations or injections, too much of that steroid can cause Cushing's. But for this morning's discussion, I'm really focusing on when Cushing's is caused by production from within the body itself. But I need to emphasize right at the start that getting this right and then getting the management right is truly one of the hardest things to get right in the whole of endocrinology. It's an extremely challenging diagnosis to make at times, and it can be an extremely challenging condition to actually manage. So it is the case that unfortunately very often there is periods of time when people can get frustrated during the diagnostic process because tests may have to be repeated, and we'll come back to that. Importantly, you need expertise, and it sort of goes without saying that if you see or are being seen by people who are familiar with the diagnosis and management of Cushing's, it's more likely that they'll get to the diagnosis more quickly, and of course it's more likely that the various management options will be laid out and the correct choices made. Where does the name come from? Well, in fact, it comes from this individual here on the left-hand side. So this is Harvey Cushing seen here. Now, in fact, Harvey Cushing was a neurosurgeon, not an endocrinologist, not a physician, a neurosurgeon. And without question, he was one of the greatest neurosurgeons of the 20th century. He did truly amazing work. And the reason why this condition bears his name is because of this individual here shown on the right. So this is Minnie G. So this is the patient who he described in 1912, having first seen her in around about December 1910. And she presented with features lacking periods. She had obesity around the abdomen. She was actually short. She had lost hair around the head. She was hypertensive, so her blood pressure was high, and she had excess hair on her face, and she was bruising. So these are the features of someone with very florid signs consistent with Cushing's syndrome. And he wrote up Minnie G here in this paper in 1912. And around about 20 years later, in 1932, he then wrote up a series of further patients and actually made the connection between the abnormal pituitary and then the adrenal glands. And this was even before the hormone from the pituitary, ACTH, which we're going to come back to, was actually described. So he really had put this syndrome on the map. And the reason why it's called Cushing's disease when it's from the pituitary is because he was the man who described it, and he was a neurosurgeon. So we have Cushing's syndrome, and then Cushing's disease is when it's specifically from the pituitary itself. How's cortisol actually made? Well, cortisol comes here from these adrenal glands, from the adrenal cortex, but it's regulated from other hormones. So we are all familiar with the fact you have your pituitary sited here, up inside the head. It's just underneath the brain. It's about 1 centimeter across, and it hangs underneath the brain, and it makes the hormone adrenocorticotropic hormone, or ACTH. That hormone passes through the bloodstream, goes to the adrenal cortex, and drives the release of cortisol. Now, the pituitary itself is under control from other areas. So we have above the pituitary the hypothalamus, and that makes various hormones that then drive the release of the ACTH down through this pathway. When we have excess drive here, then the levels of cortisol are higher, and if the cortisol levels are high over long periods of time, then that can lead to Cushing's. The difficulty, and part of the difficulty in getting the diagnosis right, is that this system is set up to maintain your health. It's absolutely essential that you have cortisol at normal regulated levels, but when it's too high or too low, people become very unwell. So when it's too high, prolonged, it's Cushing's. When it's too low and prolonged, that's when you have Addison's disease, or lack of secretion of cortisol from the adrenals. The point here, though, is that if you are acutely unwell, your cortisol levels should rise. It's driven by these factors from up in the hypothalamus. So just having a high cortisol level by itself does not mean you have Cushing's, because if you're acutely unwell, your cortisol level increases, and that is absolutely as it should be. If it doesn't increase when you're acutely unwell, then in fact you become more unwell. So it's this chronic elevation of cortisol which is driven by either the pituitary or other areas we're going to come on to that causes Cushing's. So if we then look at how this system is set up in various different types of Cushing's, here I've shown in a cartoon, this blue area here is meant to represent the pituitary gland, and this yellow area here is meant to represent the adrenal gland. If we then consider what happens in someone who has Cushing's disease, so that's from the pituitary, usually this is driven by a small tumor measured in a few millimeters, a benign tumor within the pituitary gland that makes too much of the hormone ACTH, and that passes through the bloodstream, driving the adrenals to make too much of the hormone cortisol. And cortisol here then goes off to cause all of the peripheral effects which cause the signs and symptoms to do with Cushing's, some of which were illustrated by that patient I showed of Harvey Cushing, mini G, some which I'm going to come on to in a moment. So it does that, but at the same time, cortisol also feeds back and switches off the normal pituitary's production of ACTH and switches off the hypothalamus driving the pituitary. So all of the ACTH is then coming from this small area within the pituitary. Now, ACTH can come from these types of tumors. Less commonly, it can come from elsewhere in the body. So, for example, there are some lung tumors that produce ACTH, shown here. They can then drive the ACTH to tell the adrenal glands to make the cortisol, which then feeds back. And, of course, that then switches off all the production of ACTH from the pituitary and switches off the hypothalamus as well. These two conditions are called ACTH-dependent Cushing's because it's driven by ACTH. And in contrast, we have Cushing's due to when you've got a problem in the adrenal gland itself. So you can have a nodule on the adrenal gland, or the adrenal glands can become enlarged. And by themselves, without the action of ACTH, make too much cortisol. That then feeds back to the pituitary and therefore switches off ACTH. The ACTH levels measured in the blood are very low. So we call this ACTH-independent Cushing's. And that's very, very important indeed, because what we would need to do when we approach someone with Cushing's is to first establish whether the cortisol levels are high. And if they are high, we need to work out what the cause of that is. And the first thing we do, and I'm going to show you a slide later in the presentation, is measure the ACTH level. Because if the ACTH levels are within the normal range, or if they're high, then we know it's likely to be one of these two causes. Whereas if the ACTH level is low, then we would focus primarily on the adrenal. So here's a table that we produced some years ago, just illustrating the various different types of Cushing's. So in purple at the top, we've got the ACTH-dependent Cushing's, of which Cushing's disease is commonest. So around about 70% of all types of Cushing's is due to Cushing's disease, so a small tumor in the pituitary gland. And interestingly, and for reasons we don't know, more women get this than men. We don't know the reason for that. It's just one of those things. In around about 10% of the time, we've got what we call the ectopic ACTH. So that's, for example, like the lung tumor that I illustrated. And sometimes, despite our best efforts, we have someone with Cushing's, with ACTH, but we can't actually find whether it's due to the Cushing's disease or is due to some other source in the body. The problem with these ectopic tumors is sometimes they are only a few millimeters in size, and trying to find them, because they can be anywhere in the body at all, can be extremely difficult. So differentiating between these two different types of Cushing's is the reason why we do a lot of these extra tests that I'm going to discuss. So in contrast to that, shown in green here, are the ACTH-independent causes from the adrenal, the commonest of which are benign tumors in the adrenal glands, the adrenal adenoma. Around about 10% of patients presenting with Cushing's will have that. Some patients have adrenal carcinomas, and around about 5%, so these are frequently, unfortunately, can be very nasty malignant tumors. And then there are some really uncommon causes of Cushing's where you have an increase in the size of the adrenal glands. So these are macronodular hyperplasia. There's not actually adenoma. Both adrenal glands are affected. This other condition here, primary pigmented nodular adrenal disease, when the adrenals are very tiny, but they make extra cortisol, and some other rare syndromes, such as the McCune-Albright syndrome. So these account for very, very few patients with Cushing's, but all of these in green are direct problems from the adrenal themselves, whereas here in purple, and really for this webinar, really the 70%, which is the Cushing's disease. But when someone presents with the signs and symptoms that could be Cushing's, it's all these things that will be going through our mind that we have to try and work out what's going on. So what sort of things do people present with? Well, this is just a cartoon schema, and this may be very familiar to some of those on the call. We recognize that cortisol is a hormone that really can affect every single cell in your body. And the reason for that is that cortisol gets into all your cells, and within all your cells is what we call the receptor that the cortisol binds to, and so it can have an effect. And so this is why patients with Cushing's can have such widespread effects in so many different areas, and also why the way people present can vary, because different tissues in the body are sensitive in different ways to the cortisol, and between different individuals there can be different sensitivity to the cortisol across their different tissues. So in one person, for example, there may be a lot of problem with extra weight gain, whereas in someone else there may be a lot of problem with very thin skin. Someone else may develop a lot of osteoporosis, but overall there are these different features that can affect. One of the things which is really very common indeed is alteration in mood and depression. Patients can have poor concentration. Acne is fairly common, particularly in the younger patients. Redness of the cheeks is extremely common, and increase in hair in women is also common. The thinness of the skin leading to the stretch marks or striae tends to be more common in men than in women, and the weight gain is variable, but usually it's present in most patients. In women, there can be loss of the periods in both men and women because the high levels of cortisol switch off the production of sex steroids, so that's estrogen in women and testosterone in men. There can be decreased sex drive in both women and men. And because of the high levels of effects of cortisol, the body hangs on to more fluid, so you can get swelling of the legs and feet. And the complications that people can have is high blood pressure, diabetes, high lipid, and osteoporosis, amongst other things. So this is by no means an exhaustive list. And of course, people can present with either very severe Cushing's or mild Cushing's. When Cushing's is very severe, it is easier to make the diagnosis. When it's very mild, although people can be very debilitated by that, it's much harder to get the diagnosis right. So Cushing's disease is when we have this here, small tumor in the pituitary. It's releasing too much of this hormone ACTH. It's driving the adrenal glands to make more cortisol. It's not very common, so when it is proven by operation, and we know that when we look at the sample in the microscope, we can see that there's a tumor making the ACTH, around about 4 or 5 people per million population will present per year. It doesn't appear to matter whether you are living in the UK or elsewhere in the world. There doesn't appear to be much of a difference between different ethnic groups. It's fairly common across the board. Sorry, not common, it's fairly consistent across the board for all these different types. And because cortisol affects all the cells in your body, you have these widespread effects. So in terms of investigating people for Cushing's, it's really important that this is done in a stepwise fashion. And the first thing is there needs to be a reason why, from a clinical perspective, people should actually have an investigation performed. And if that is done, and I'm going to come on to that in the next slide, then once there's a clinical index of suspicion that's strong enough, then there needs some testing to see whether or not there is chronic biochemical excess of cortisol. So that is, does the patient have Cushing's syndrome, too much cortisol? And then the question is, if that is proven, and only once that is proven, what then is the cause? And it's absolutely essential that in terms of going through the diagnostic steps, it's very, very important that physicians and patients don't move from step 2 to step 3. It's essential that Cushing's syndrome is established first before going on to any of the other tests that we might use to try and establish the cause. If we don't do this, mistakes are made. And the reason mistakes are made is because, for example, someone may have an ACTH level measured, but of course ACTH levels are normally in the normal range in people who don't have Cushing. So it doesn't tell you that that person has Cushing's. And people can then start making mistakes about what the meaning of that test result is. So this is really the crucial step, step 2 here. In terms of the signs and symptoms, so we wrote these international guidelines now nearly 10 years ago. They've been looked at and really they still stand to be true. And so these are the guidelines that physicians seeing patients with Cushing's hopefully will have read and hopefully will find useful to try and help patients and to try and make sure that the right test is done in the right people and people have their diagnoses established. And you'll see here that the most discriminatory features of cortisol excess are these ones I've listed here. So the facial redness, proximal myopathy means weakness of the muscles, so particularly weakness of the upper leg muscles, and very often patients have problems either rising from a chair or sometimes getting up downstairs. And when we listen to patients tell us their story, we can hear how that feature can become progressive over months or sometimes years, and then raises the suspicion of someone with Cushing's. The striae, if they're wide, of course the problem with striae is they're very common in younger normal individuals during their teenage years. They can have some of these stretch marks. Usually they're not as wide, and usually they come on over a matter of months and then fade after a matter of months. Similarly, people who either put on or lose weight quickly can get some stretch marks, again, not typically quite so wide. Bruising is a very common feature, and thinning of the skin is a very common feature. And these are features which are very useful to help us discriminate between someone who might have Cushing's or may just have some weight gain from some other cause. In children, a child who presents with increasing weight and a decreased rate of growth is almost what we call pathognomonic. It almost tells us that that is Cushing's. There's very little else that causes a child to put on weight and stop growing. And so that's a very useful indicator of Cushing's in a child. But Cushing's in children, fortunately, is even less common than it is in adults. Other features which are common in the general population that ring warning bells in doctors' heads should be if a young person has a combination of a high blood pressure, diabetes, or perhaps who has osteoporosis. So, for example, a young man who presents with a crush fracture in their vertebrae due to osteoporosis, we'd have to think about Cushing's very carefully. Now, I show this slide because these are the most discriminatory features, but of course people have many, many other features. And features which are often described in Cushing's and are often present in Cushing's are listed here. The problem is that these are less specific to Cushing's and are very common in a range of other conditions in the general population. And a lot of other symptoms, such as fatigue and weight gain and, of course, mood change, are very common problems. Lack of periods or the polycystic ovarian syndrome, again, very common in people who do not have Cushing's, even though these are frequently present in people who do have Cushing's. So these are the reasons why trying to get the diagnosis right can be so difficult. One important emphasis that we make is that there shouldn't be a single feature in someone's history or someone's clinical features that would prompt a consideration of the diagnosis. But of course, at the same time, if you've got a number of mild features together, that could prompt it. So someone may have mild increases in blood pressure, rather other subtle changes, perhaps they have diabetes, perhaps they've had osteoporosis. Each individual not being too severe, someone's not feeling well, they're wondering about Cushing's. If there's a combination of a variety of things, that then is certainly a reason to at least consider the diagnosis. But in contrast to that, a very strong recommendation that we have made is not to be screening blood tests or urine tests or saliva tests in a range of people just indiscriminately. So, for example, one of the questions that was raised is, could Cushing's be an underlying cause of many people with diabetes? And the answer is no, it's not an underlying reason for many people with diabetes. And actually, using lots of tests in people who simply have another condition to try and find people will lead to an awful lot of false positive tests and a lot of problems, causing a lot of extra investigations that would not be justified. So it comes back to this notion of trying to make sure that the tests are done appropriately in the people in whom it's more likely that they would have Cushing's in the first place, accepting that the features that they have may not be all the classical features as shown in the very first slide with mini-G. Hopefully we'll be picking up people much sooner than that and with a much less severe disease. Of course, whenever in medicine we're faced with trying to pick up milder disease, that's always much harder. What are the tests that are used? So the tests that we'd recommend are two of these three following tests. And the three tests are either what we call 24-hour urinary free cortisol, a late-night salivary cortisol, or a dexamethasone suppression test. So if I take the urinary free cortisol test first, so this is a pain to do. It's a pain for patients to have to collect the samples. You've got to collect all the samples for the 24-hour period. You need at least 2 measurements, and some people would argue you need even 3 measurements. And the reason for that is that the level of urinary free cortisol can vary quite a lot. And what this test is doing is that the cortisol passes around in your bloodstream, and it carries on a protein in your bloodstream called cortisol-binding globulin and some other proteins. When all those are occupied by cortisol, any extra cortisol spills out in the urine and is measured as the urinary free cortisol. So the urinary free cortisol, there's a range between a lower level and a higher level, and once it's above that higher level, it's consistent with too much cortisol being found. If the levels of urinary free cortisol are 3 or 4 times the upper limit of normal, that really is very consistent with someone with Cushing's. Frequently, however, the levels are much less elevated than that. And in fact, the urinary free cortisol is not a particularly sensitive test to pick up someone with Cushing's. The late night salivary cortisol test is a very sensitive test. So what normally happens is your cortisol levels, if you don't have Cushing's, are high in the morning and then fall to low levels in the evening and late night. And so if you measure the salivary cortisol late in the evening and it's high, that is then consistent with Cushing's. The difficulty is that this is a very sensitive test. So in fact, people who are either on shift workers or have other intercurrent illness or other problems can have elevated salivary cortisol without Cushing, so that's then a problem with potential false positives. And then we have a dexamethasone suppression test that's either an overnight test or a 48-hour test, and what happens in normal people when you take the dexamethasone, the cortisol levels are low, but there are a variety of tablets and other things that can interfere with this, so it's important that when these tests are done, that's taken into account, and the tests are avoided if they're going to be things that complicate the interpretation of the test. For example, if patients are on estrogens or the oral contraceptive pill, then this test would be unreliable. None of the tests are perfect, and there may need to be repeated tests, particularly in the context of this thing called cyclical disease. So now, cyclical disease can be very, very challenging to get the diagnosis right. This is where the levels of cortisol are increased or decreased and they fluctuate. We really don't know why this happens. It relates to the tumors releasing varying amounts of the ACTH or occasionally some patients with adrenal problems directly, so the primary pigmented nodular adrenal disease can release varying amounts of cortisol directly. But focusing on Cushing's disease itself, you get these fluctuations and the levels can be high and low. To do the best investigation of that, we would normally recommend the use of salivary cortisol. We can give patients a number of tubes. They can spit into the tubes, and then when the levels go up, we can then call them into the hospital to investigate them further. But it's still difficult to get right, and it needs to be guided by clinical judgment. Once Cushing's is confirmed, so we just go back one slide, so this is to confirm Cushing. So those tests, you need at least 2 of those, 2 out of the 3 confirmed to be absolutely sure someone has Cushing's, and only then will we move to the next stage, which is what is the cause. And that's shown in this slide here. And once that's done, I would strongly argue that all of this on this slide should be done at an expert center. And in that center, the first step is to measure plasma ACTH, and often that's done in secondary care and district general hospitals first, so we often have some idea. If the level of ACTH is low, then we are into ACTH-independent Cushing syndrome. We would image the adrenal glands, and then we can see whether there's an adrenal problem with a variety of different causes. Occasionally, even though this appears to be from the adrenal, we don't see very much. In that case, there might be this rare condition, primary pigmented nodular adrenal disease, or we just have to question whether or not the person could be taking exogenous glucocorticoids, so tablets, creams, or anything else. Hopefully we wouldn't have got to this stage because we would have wanted to take a very careful history of whether any extra steroids had been taken. Conversely, if the ACTH levels are consistently high, we would use pituitary MRI scans to look at the pituitary, and we would do a thing called a CRH test, that stands for corticotrophin releasing hormone test. And in that circumstance, if the MRI scan clearly shows a pituitary lesion, and we usually recommend more than 6 millimeters, and there is a positive response to the CRH test, and there has been some suppression on dexamethasone, then this would then be consistent with Cushing's disease, and many centres would be happy to consider recommending pituitary surgery. However, if there isn't a clear tumour on the MRI scan, if it's small, if we don't see anything, or if these tests are inconclusive, we would normally recommend what's called bilateral inferior petrosal sinus sampling, or BIPSS. And this is a very specialized technique that should only be done in very specialized centers, where small plastic tubes are steered up to near where the pituitary is, and the ACTH is sampled from near the pituitary and then compared to a sample in the arm. And the reason for doing that is we're looking to see whether there's a higher level coming from the pituitary than in the rest of the circulation, to confirm a diagnosis of whether it's Cushing's disease or whether it could be ACTH coming from somewhere else, for example, the lung. If we find a gradient, then this positive gradient allows us to make a diagnosis of Cushing's disease, and even in the absence of seeing anything on an MRI scan, we can recommend surgery. If we don't have a gradient, then we've got to go looking for an ectopic tumour, which involves an extra test I've listed here, but I'm not going to discuss further. The problem, though, or one of the major problems, is around about 40% of patients who are proven to have Cushing's disease have a normal MRI scan. So not seeing anything on the scan does not exclude Cushing's. We already know they've got Cushing's syndrome, which is ACTH dependent from the biochemical tests that have been done before getting to this slide. But the problem we have is seeing something on a scan doesn't prove that you've got a tumour, because around about 10% of the population have got a small change in the pituitary. And the reason why that's important, it just emphasises why it's so important to make sure that someone has Cushing's syndrome, which is ACTH dependent, before doing any scans, because it's very common that we can pick up small areas in the pituitary which can then lead to false diagnoses and wrong pathways. Once Cushing's disease has been established, the first line of treatment is pituitary surgery by an expert pituitary surgeon, and this nowadays is done by going through the nose, up through what we call the sphenoid sinus. So at the back of your nasal cavity is a bone. This can be breached, it's rather thin, and then another bone is breached here and allows access to the pituitary. Increasingly, neurosurgeons are using what we call an endoscope. Traditionally, they could use what's called an operating microscope. There really is very little to choose between the two techniques, other than saying that with an endoscope there appears to be much less bruising and problems in the face after the operation. But really, it doesn't matter which technique the pituitary surgeon uses in terms of outcome. What are you going to feel like if you've had successful pituitary surgery? Well, if you remember back to that slide I was showing at the beginning, when you've got Cushing's disease, the rest of the normal pituitary is switched off. And because of that, the body's production of cortisol is usually asleep for around about 6 to 12 months, and it's sometimes longer than that. And this means there's an absolute requirement to take glucocorticoids, and then really hydrocortisone in the UK is the mainstay of treatment. And this is at replacement therapy doses. So in most patients, when they've been established, in the region of about 20 to 25 milligrams of hydrocortisone total daily dose, 10-5-5 or that type of dose. I have to say, usually we give patients a little more hydrocortisone, at least for the first few weeks, because otherwise they've gone from very high levels of cortisol to very low levels of cortisol, and that can contribute to them feeling lousy. We educate people about sick day rules, so making sure they know when to increase the hydrocortisone, and every patient we see gets a hydrocortisone emergency pack. But one of the things I emphasize to patients when I see them, and so this is before they get to see the neurosurgeon, is that they will usually feel worse for the first 6 to 12 months after they've had their operation. And it's very common that patients will think that, well, I'll be different, I'll be fine, I won't feel like that. But in fact, it is very, very standard that the majority of patients I see feel worse for the first 6 to 12 months and then gradually improve. Sometimes it takes up to a couple of years for people to feel better, but I think it's very important that patients are warned about this. Muscle strength, I always tell patients, is one of the slowest things to improve from the physical perspective. Often takes 6 to 9 months or sometimes more. And part of the reason for this, what cortisol does is it breaks down protein, and the muscle take a long time to recover from that. Patients may often get frustrated and want to go to the gym and improve like that, but it is the case that it just takes time. And one of the analogies I use is that it's often taken 2 or 3 years for the Cushing's to develop. It's going to take 2 or 3 years for you to recover from the terrible effects of cortisol. And one of the other areas which is very important is patients' quality of life can be impaired, and depression and problems with concentration can last for a long time after the Cushing's, even years afterwards. And this is because there are direct effects of Cushing's on the brain, and in fact on the brain structure, and that can take a long time to recover, and that can be a particular issue in some patients. So the problem we have is that even when surgery has been successful, there can be recurrences. So if we look at the huge numbers of series which have been done, so we've analyzed data on around about 5,000 patients who have had operations for Cushing's, up to around about 25 or 30% of patients can at some point experience a recurrence of disease, and that means it's important for patients to have access to endocrinologists who are going to be able to follow them. And the recommendations is that people are seen usually every year or two, really for the rest of their lives. Because in that circumstance, if there is a recurrence, there's further things that need to be done. So when Cushing's disease is confirmed, we'd ideally go for a tumor resection. The patient hopefully will go into remission, and that occurs in around about 70% of the time. And then we'd need to monitor for recurrence. If resection is not possible, or if there's a recurrence, then the cortisol levels need to be controlled, and there's a variety of different ways of doing that, including further surgery, other medical treatments which act on the adrenal gland. We can consider radiotherapy to the pituitary or some other medical therapy that affects the way the pituitary works, or combinations. And of course, one of the ways which Cushing's can be absolutely fixed is by taking both adrenal glands out, but then of course patients require to take hydrocortisone and fludrocortisone therapy for the rest of their life. So in conclusion, there are a lot of pitfalls, and care needed to get the diagnosis right. Finding out the cause of Cushing's needs to be done in expert centers. Pituitary surgery remains the first-line treatment, but patients just need monitoring in the long term. I think it needs to be emphasized again, recovery takes a long time and can be expected to take a long time, and that even when the tests and clinical changes suggest that someone has gone into remission for their Cushing's, I'm afraid that some patients, despite everyone's best efforts, still have ongoing problems in some aspects of the Cushing's that they experienced prior to treatment. And with that, Sammy, I'll stop, and I'm happy to take questions.
Well, thank you very much indeed for that presentation. I've certainly learned a lot from this morning. Very pleased to see we have lots of questions that have come in, and maybe if we just have a look starting from the top. I think some of them may have been partially answered by your presentation, but hopefully you'll be able to answer the other ones that people have been typing in. So here we are. We've got the first question is about somebody who is 18 months post-op adrenalectomy and is hydrocortisone dependent, and asking what are the chances of feeling better. This person unfortunately seems to have just gym symptoms pre and post-op. I'm not sure which is worse, so whether you can comment on that at all, please.
So I guess my question is, if this is, so if someone has one adrenal tumor and on one side, and that is taken out, then very often the other adrenal gland can remain suppressed, and the cortisol remains suppressed because of the effects on the body for many months, sometimes 2 years, sometimes longer. And during that time, there is a need to take hydrocortisone replacement therapy. And the problem we have is we recognize despite the best way of replacing hydrocortisone, it's not the same as having your own cortisol. So when people are on hydrocortisone replacement therapy, they may not feel as well as if they weren't needing hydrocortisone at all. Most patients feel better on that treatment in the long run than they did when they had their Cushing's, but nevertheless some people don't feel completely right. In answer to the inquirer's question, I think it depends if their question is whether they've had one adrenal gland out. I would hope if they've had one adrenal gland out, there would be optimism as the dose gets reduced that their other adrenal would eventually wake up. If they've had both adrenal glands out, they need both hydrocortisone and fludrocortisone, and that needs to be titrated and carefully monitored to what their needs are. But unfortunately, despite all of that, it comes back to what I originally said, some people with Cushing's continue to feel unwell despite all of the blood tests and all the biochemistry being right. And this is partly down to the bad effects that cortisol has on the brain. It alters brain structure. And we know there are studies showing that brain structure and volume and other changes can continue to improve up to 5 or more years after the treatment of Cushing's. So I can't completely answer the question. The point is that people vary and it can take time, and it's just important that all of the things that can be treated and monitored and altered are done as precisely as possible.
Thank you. And that actually leads quite nicely on to the next question, which someone has had one adrenal removed and is wondering if it's likely they will need the remaining adrenal removed as well, and apparently they're currently being monitored.
Okay, so it depends on again, it depends on what the diagnosis is here. So if someone has Cushing's disease, that's of the pituitary, both adrenal glands will be making extra cortisol. And if you remove one adrenal gland, then the other adrenal gland will continue to make cortisol, and eventually what happens is it will get bigger under the influence of the pituitary making more of the ACTH, and you'll probably get your Cushing's back unless you do something to the pituitary itself, such as radiotherapy. But that treatment where radiotherapy is given to the pituitary and one adrenal gland is taken out can actually be a very effective way to treat Cushing's. And in Europe, in a place called Leiden, there are a lot of people treated like that very effectively. If it is the fact they've had one adrenal gland taken out because they've got what we call bilateral macronodular hyperplasia, then that's usually a less severe form of Cushing's. You can take out one gland, and often then either that's fine for many years, or indeed it can wait for a number more years, but ultimately quite a lot of people end up having to have both adrenal glands taken out.
Okay, thank you. The next question asks, what can be done if a health authority won't sanction saliva tests?
I'm very surprised about that. Yeah, so salivary cortisol tests are not expensive at all. They probably cost about 20 or 30 pounds per test, or less than that. And I think that it depends on the familiarity that endocrinologists have with salivary cortisol. The UK has been a bit slow at adopting salivary cortisol compared to Europe and the rest of the world. Part of that is down to the fact that in the UK it traditionally has been easier to bring patients into hospital to do tests. And the original way of doing the test was to measure a blood test late at night. In fact, I and others published the first big paper on that back in the mid-1990s on using a blood test late at night as an inpatient. Now, salivary cortisol gets around that by virtue of the fact that you can get the same information usually without bringing people into hospital. So I would be surprised if there were many barriers to physicians getting a salivary cortisol, because the test can be done, it's usually sent to a laboratory that's measuring it, and so I think that's a question that would need to be taken up with the endocrinologist. It's not an expensive test.
So is it just a case of the person being a bit more, of just persevering?
Well, I think so, but of course the caveat, and it's important to remember though, is that salivary cortisol, of all the tests we would use, salivary cortisol is the one that is more likely to give false answers. Okay. And the reason I say that is because the levels can be high just because someone's either unwell or they're taking it at a slightly different time. If you've got any problems with your teeth, then there can be a tiny leak of blood from the teeth, and that contaminates the saliva sample, and that makes the levels much higher because the levels in blood are much higher than in the saliva. Lots and lots of reasons. Having said that, if the salivary cortisol level is below the range, that really means you haven't got Cushing's. That really excludes it. So that's a good way of looking at the test, that if the test is done and it's normal, that really tells you that there isn't Cushing's at that time.
Fine, thank you. And the next question is about cyclical Cushing's.
Yes.
The person has asked, let's say that 3 doctors have high clinical suspicion, various mildly elevated cortisol levels over 5 years, and various different methods. And are there any guidelines about when to test?
Well, the guidelines that there are, we would suggest testing when patients have symptoms. Now that varies greatly because sometimes the cyclicity is either measured over weeks or months and occasionally over years. It's very difficult because, of course, by the time the patient ends up getting to see someone, it may have cycled out. So therefore, this is where the salivary cortisol can be useful. And it can be useful by patients having some tubes which they can then spit into and then get sent off. But that needs to be set up in an arrangement with an endocrinologist that's seeing them, and also who has a sufficient index of suspicion that that is what's going on. So getting cyclical Cushing's right is difficult. There is no way round. I can't make it any easier because it's just not easy.
So the tests are not conclusive. It's just a case of persevering again. And
well, of course, the other thing to say is that if the tests are done and they show that at the time the tests are done that there really is little evidence of Cushing's, then it is unlikely that that particular individual's symptoms are being driven by huge amounts of cortisol excess. And you can have patients with cyclical Cushing's who have hugely high levels that then go down to normal or unnormal, and you can have people who get little bits which are just slightly increased and then are actually pretty much normal again. I think it's that latter group where it's very difficult to actually establish a diagnosis. And the problem we have is the test you might want to use for cyclical Cushing's are exactly the tests where, if they're positive, it could be a false positive, like the salivary cortisol. If a salivary cortisol test is normal at the time when someone thinks their disease is quote-unquote cycling in, that really tells you that however they're feeling is not due to Cushing's.
Okay, thank you. So the next question asks, if people are taken off hydrocortisone early, is there a higher risk of the tumour recurring?
Okay, so that's a really good question, and the answer is no. It's a really good question, but no. The thing that limits the speed with which you can have your hydrocortisone dose reduced and stopped really depends on the time it takes for the rest of your pituitary and hypothalamus to wake up to then drive the adrenal glands to make cortisol. And to a great extent, the longer that time takes, the more reassured I would be as an endocrinologist. So if I see someone and it takes them 9 to 12 months or longer to come off their hydrocortisone after an operation on their pituitary, then that usually bodes well for the future. If someone finds that their cortisol levels, which were low after the operation, are then coming back and becoming easily detectable, and it's possible to get them off hydrocortisone after 4 to 6 months, I'm afraid that usually means they're going to experience a recurrence of their Cushing's quite soon.
Thank you. That really answers
it's not that taking them off the steroid encourages the tumour to come back. It's the fact that if they can come off the steroid early, it's because the tumour is more likely to be coming back.
Yeah, and so that really answers the next question as well. So really it's very individual.
very individual indeed, and so what we tend to do is people would have their 9 a.m. Serum cortisol measured before they've taken the hydrocortisone in the morning every 3 months, and when the level gets up to around about 200 nanomoles per litre, we then do a synactin test to see whether we can take them off hydrocortisone.
Thank you. The next question, I think you may have partly answered it, but it's asking why endocrinologists perhaps dismiss patients even when they have high serum cortisol, but the dexamethasone and urine tests are not conclusive.
Sorry, I missed the first part of your question, Sammy.
I think you've probably answered a lot of this question in your presentation actually, but the question asks, why do endocrinologists dismiss patients even when they have high serum cortisol, but the dexamethasone and urine tests are not conclusive?
Well, okay. It depends what's meant by high serum cortisol. The serum cortisol value, it depends on what time of the day you're taking it. So it's really a question of how likely, from a clinical perspective, is it that someone has Cushing's? And then based on that judgment, then interpreting the test. So for example, if I see someone who really presents with everything that would suggest to me that they have Cushing's, and I do a dexamethasone suppression test, and that shows a suppression of the serum cortisol, which would normally exclude Cushing's, I would go, well, okay, but I'm not sure that test's giving me the right information. We know around about 5% of patients with Cushing's disease suppress on dexamethasone suppression testing, but I'd be using more than one test. So for example, if they also had a salivary cortisol test that was low and the dexamethasone suppression test was also low, 2 tests in the same direction, either showing they do have Cushing's or don't have Cushing's, is really what you need to have greater reassurance about the diagnosis. So in answer to the question, it comes down to making the right judgment based on clinical experience and also making sure that more than one test is being used. And if there's doubt, then the test should be repeated at an interval.
Okay. I'm very conscious of the time, Professor. Is it all right if we carry on?
I'm fine, carry on. No problem, carry on.
Okay, thank you. The next question asks, if someone has both a pituitary tumour which is secreting and an adrenal tumour that may be, how long after the pituitary surgery would you be able to tell if the adrenal tumour is secreting? Okay,
so it would be unusual to have a cause of the Cushing's driven by a ACTH secreting tumour of the pituitary and to also have a tumour of the adrenal gland. What can happen though is that when people have had their Cushing's, Cushing disease, the ACTH in the pituitary can cause the adrenal glands to become rather nodular, rather lumpy. And sometimes what happens is that even when you take the pituitary out, these little lumps can be making cortisol by themselves. And that can, in fact, effectively, they can continue to make cortisol without the ACTH doing it, which means that you take out the pituitary and unfortunately there's still some cortisol problems. It would be very unusual indeed to have both a pituitary problem and a separate sort of adrenal problem itself. In answer to the question, if you have an adrenal, if you have a pituitary operation and the cortisol level is not low after the operation, and if it was known before the operations that there were these nodules on the adrenal glands, then it may be possible for the cortisol levels still to be high. And in terms of making those assessments, it'll be back to making clinical assessments, it'll be back to using the sorts of tests we've already discussed to work out whether the levels are high and are being secreted by the adrenal gland itself.
Thank you. So the next question asks, how long after pituitary surgery would you expect proximal myopathy to improve? This person is nearly 2 years post-op, but still very interested.
So 2 years post-op is rather a long time, and the question then is there something else causing the muscle weakness? On the assumption that the amount of hydrocortisone that is being taken is not excessive. So it would be unusual for someone to persistently have weakness for that period of time after. I'm not saying impossible, but just unusual. And it just makes me wonder whether there might be something else going on. And that's something to be discussed.
There is evidence, I think, of arthritis. And so it's more than likely, if it's this long after the operation, that it may be the arthritis which is causing those symptoms rather than the effects of the cortisol.
So important that there's a distinction made between muscle weakness and difficulty in movement because of joint pain. But if the muscles themselves are actually weak, and of course it could be because, as you suggest, the arthritis is preventing the muscles from being used properly, and that would sort of prevent the retraining of the muscles and the development. That could, of course, contribute. But yes, that could be a contributor, and of course, very important if there is arthritis, if it were inflammatory arthritis, that if the patient is receiving treatment for that, that could also itself, for example, extra steroids impact on the muscle strength. But if it weren't for any of those things, 2 years is getting to the sort of period of time where I'd be thinking that something else might be going on.
All right, okay, that's really helpful, thank you. One question is asking what effect does growth hormone have on thyroxine levels?
What effect does growth hormone have on thyroxine levels?
Yes,
growth hormone doesn't really have any particular. Is it? I mean, I don't. The patient, the inquirer may not be able to say exactly what they mean. So usually growth hormone has very little impact on thyroxine levels at all. There's no real relationship. So if you have someone who is on growth hormone treatment, for example, we don't have to adjust the thyroxine levels because of that if someone's either making their own thyroid levels or they're on thyroxine treatment. In contrast, again, not related directly to Cushing's, in someone with pituitary disease, occasionally, if they're already on hydrocortisone, occasionally we have to make a small increase in the hydrocortisone when the patient's been put on growth hormone because of the way the growth hormone affects the metabolism of cortisol, but not really with thyroxine.
Okay, thank you very much. The question asking, have you had cases of ectopic Cushing's and where have the tumours been?
The answer is yes, many. The predominant place is in the lung. These tumours can either be very, very tiny, what we call neuroendocrine tumours in the lung. Occasionally they can be larger tumours, so nasty small cell lung cancer can cause it. And then the next most common area is in the pancreas. We've had patients with the small neuroendocrine tumours in the pancreas causing it, but to be honest, you can actually get it in many other places. For example, there is areas in the thyroid with the medullary thyroid cancer that cause it, and actually you can find these neuroendocrine tumours in a wide range of different places, but the majority of them are in the lung.
Okay, thank you. Another question we have is bilateral adrenal nodular hyperplasia a progressive condition?
Slowly is the answer. So typically, if it's typically it tends to present rather more slowly with rather milder Cushing's. Typically, not always. And usually what happens is slowly by slowly it tends to result in more of the features with Cushing's. And that's important because if it's then treated by having one of the adrenal glands taken out, it sort of halves the amount of cortisol that's being made, because normally the bilateral hyperplasia is usually fairly similar in size. Usually one side is slightly bigger than the other side. If you're going to do an adrenal operation, you usually take out the larger side. And that then can improve the situation for a number of years, but slowly by slowly it is then sometimes necessary to take out the other adrenal gland. And so in that sense it can be progressive, yes.
Okay, thank you. Okay, this is an interesting question. Can you give any indication as to what the damage to brain cells might be with Cushing's in terms of predisposition to dementia later in life?
Oh, that's a good question, and I don't think I or anyone else in the world knows the answers to that. I don't think we've got I don't think we've got any. We've got no suggestion on either clinical experience or indeed looking at all the series of patients that Cushing's predisposed to dementia.
Okay, thank you. Again, the next question, I think you've probably answered it. It's asking, is dexamethasone suppression test conclusive, or have you seen patients with Cushing's who haven't suppressed?
So normally, so if you don't have Cushing's, you take the dexamethasone and your serum cortisol is suppressed. That's a normal response. When you have someone with Cushing's, then you take the dexamethasone and you're looking for the cortisol still to be detectable afterwards, i.e. it is not suppressed. Have I seen patients with Cushing's disease who have had a dexamethasone suppression test where it has suppressed? Absolutely yes. Is that common?
Okay.
No.
Fine, thank you. Another question we have, if you have something like cerebral palsy, would the Cushing disease elevate the cerebral palsy, for example, muscle weakness?
I think it would. Well, if you had another condition where other parts of the body are already affected, yes, that can be exacerbated. So, for example, if you have got issues with muscle strength and you get Cushing's on top of that, then yes, I'm sure that would impact in a greater amount.
Thank you. A question about metyrapone. Does it work for everyone in reducing cortisol levels?
It's pretty good. It doesn't work for everyone. Not everyone can tolerate it. The doses that are needed vary, and sometimes the doses need to be increased considerably. But usually when the dose is escalated sufficiently, it usually makes a pretty decent improvement in most people. The reason why it doesn't tend to work is because the doses aren't increased enough. And in fact, we know that. We've actually published data on this the year before last. We surveyed 15 major centres in the UK and looked at how metyrapone was being used. And even in centres which were used to using it, there was certainly a need to use higher doses in a proportion of patients, and that would achieve a better outcome. There are some tolerability issues. Some people just don't find it very tolerable, but if it's taken with milk or other dairy products or with food, it tends to be better tolerated. The doses need to be spread across the day because it only works for a number of hours, and so most people will need 3 doses a day, sometimes 4 doses a day, from first thing in the morning right through to late at night.
Thank you. And the next question sort of leads on from that, really. After pituitary surgery, a bilateral adrenalectomy and radiotherapy, and still producing cortisol, I have started metyrapone. Do you have any suggestions for any more possible treatments?
So I'm sorry to hear that. Most times when people have had bilateral adrenalectomy, if it's been done successfully, immediately after the operation, the cortisol, when someone's had Cushing's disease and they haven't been fixed after the operation, when you have a bilateral adrenalectomy, we would normally expect the cortisol levels to be absolutely low. Occasionally, then what happens is that the action of the ACTH from the pituitary, which is still making it, causes other areas in the body to encourage the enlargement of what we call adrenal rest tissue to start making cortisol. And those areas are not necessarily just in the adrenal gland. It's not common, but it does happen. And if someone has had an adrenal surgery and after the operation there is still high levels of cortisol immediately, that would suggest to me that the adrenal surgery has not been completely successful. And so the first thing is I would want to know, what did the adrenal scan look like immediately after the operation? Are they absolutely sure the adrenal glands have been fully removed? If this is something that's come on months or years after the adrenal surgery and you've still got cortisol in that context, then yes, metyrapone can be used to control things in the hope that eventually the radiotherapy will have its effect on the pituitary and therefore the drive to the remaining adrenal tissue will diminish. Another way of potentially treating things if the adrenal tissue can't be found is you could use a drug called mitotane, which is a drug we usually use for adrenal cancer, at lower doses to control things, and over many, many years of treatment, that can actually cause the destruction of remaining adrenal tissue. So that's a long answer. There's quite a lot in that question because it all hangs on really when this particular problem rose after the adrenal surgery.
Okay, we have another question asking what is the normal range for a late-night salivary test?
It depends on the assay that's being used, and the assay ranges vary.
So simple as that.
Simple,
Okay.
as simple as that. And so you can't just take one level.
Okay, thank you. And I think one final question is, what do you feel about replacing hydrocortisone by the circadian cycle? Is that like taking hydrocortisone at various times during the day?
Well, we aim to try and do that. So, and we can't get it right. So the normal circadian rhythm is that when you wake up in the morning, or just shortly after you wake up, your levels peak. And then the levels gradually fall during the morning time. You get a little increase at lunchtime, it goes down, a little increase in your evening meal, then it goes down. And when you're then sort of relaxed late at night around about 10 or 11 p.m., watching television or going to bed, the levels are really quite low. And then they become really very low from that time until about 3 o'clock in the morning or so. And then the levels gradually build up again and reach a peak when you first wake up. None of the way we give hydrocortisone matches that circadian rhythm. There is no way of doing it because hydrocortisone has a very short action life in your bloodstream. So of course what we do is we give a higher dose in the morning when people wake up, but in fact patients wake up having no, or very often no hydrocortisone at all. This is when they are completely adrenally insufficient. And so you've got a lag, which is why we encourage people to keep the hydrocortisone by their bedside, take it first thing in the morning, because then it gets into their bloodstream quite quickly. But of course it's nothing like what your body would normally be doing. Then we say a smaller dose at lunchtime and a smaller dose in the evening, and then not to take it too late, because of course you would normally have very little cortisol in the very late evening through to about 2 or 3 a.m. So that's trying to mimic the circadian rhythm. There's no other way of doing it. There are developments being made in this area to try and give tablets where you might take it at night time. It's not released for a few hours and then the levels gradually build up during the day. They're being trialed at the moment, but that's still some way off. There are some patients who receive pump therapy with hydrocortisone, and that's been used to try and mimic the circadian rhythm in that fashion. And indeed, there have been studies looking at that and comparing how that works compared to tablet treatment. And interestingly, the studies that have been done, which have been published, haven't shown a massive, huge benefit of the pumps compared to tablet treatment. So that was published in one of the American journals about 2 years ago. Nevertheless, there are reports of some patients who find that their quality of life, etc., have improved on pump therapy. So I think the answer to the question is we are absolutely keen to try and give people better hydrocortisone replacement therapy. It's just very difficult to do. Occasionally, some patients report that if they set their alarm clock for 3 o'clock in the morning, take a tablet then, that actually they feel better and they then go back to sleep. And of course, the cortisol levels will then be increasing, but actually it's still increasing quite early. One concern is the notion that you take cortisol last thing at night. That doesn't make sense to me. And the reason it doesn't make sense is your cortisol levels should be low between the hours of around about 11 o'clock through to about 2 or 3 a.m. in the morning. And so taking it last thing at night is actually disturbing that normal rhythm. And then we know from other areas in medicine where that rhythm is disturbed, it can be associated with more osteoporosis, more diabetes, more heart disease, etc. So it's important that we try and get better ways of giving hydrocortisone or cortisol. Yes, circadian rhythm would be an ultimate goal, but it's going to be very difficult with even the very best tablets ever to match the circadian rhythm that occurs naturally.
All right, thank you very much. And we do have one final question asking do we have a list of centres of excellence for diagnosis in the UK? And I think, at the Pituitary Foundation, we do actually have a list of centres of excellence which we can tell and give advice to people. So if somebody would like to phone our helpline service, we'd be very happy to help them on that one. Okay, so I'm sure everyone will agree that this webinar has been invaluable. We've had lots of very positive comments, so thank you for that. I hope you've enjoyed taking part. I personally would like to thank Professor Newell-Price for his presentation and his valuable time in answering questions. As mentioned at the beginning, a recording... Sorry.
Yeah, it's been an absolute
a recording... Oh, thank you very much. A recording of this session will be made available on our website very shortly. But thank you to everyone who's participated today and making it the success it has been. Our aim, as you know, is to support pituitary patients and anyone affected by pituitary disease. And in addition to the webinars, we are providing the telephone and email helpline services, and we are going to be extending that to a new helpline text service from the 30th of June. We also provide a specialist nurse helpline, telephone buddies, and have local support groups available throughout the UK. Your support for us as members is extremely valuable, and we'd like to encourage more patients to join our amazing community, so please spread the word. Thank you to everyone involved. Enjoy the rest of your day and take care.